Welcome everybody. And so I'm going to speak, and then it's going to be Reena, Val, and David. So first of all, I want to thank the Department of Medical Education for sponsoring us to go to the AAMC. It's always a great chance to learn about what other schools are doing throughout the country and catch up with colleagues at other institutions. I went to several sessions about medical student mistreatment. It was a hot topic at the AAMC this year, and I'm going to talk specifically about a plenary I went to. So I don't have anything to disclose. And so my objectives for the next few minutes is to talk about the AAMC definition of mistreatment, and I'm going to talk about how other medical schools have used strategies to limit the mistreatment of learners at their institutions. So the main panel I went to was a plenary that was sponsored by the Alliance for Clinical Education, or ACE, and that's an umbrella group that includes a lot of the clerkship directors from different specialties, clerkship directors, internal medicine, the PEDS clerkship group, OB clerkship group, et cetera. And they were a good group to talk about this because they could give you a broad perspective. And as you can see from the presenters, they were geographically from different parts of the country, and they represented different specialties, including surgery and internal medicine. One of the things I thought was most interesting about this session was they really talked about the history of the issue. You usually think of this as a very recent issue or a topic that's come up more recently. But they had quotes and instances from over the past 100 years where students felt marginalized, mistreated, that the learning environment was toxic, and that those had real effects on not only their learning, but their well-being. The modern study of this issue started in 1990 when two studies came out in JAMA that looked critically at this issue and really put it on the map. And there was an editorial that captured these called The Traumatic De-Idealization and the Future of Medicine. In response to that, the AAMC started putting questions about mistreatment on their GQ. That's the graduation questionnaire, which is the survey that goes out to all fourth-year medical students towards the end of their medical school tenure, which asks all sorts of things about curriculum, student life, et cetera. And so from 2001 to 2011, an average of about 17% of medical students reported they were mistreated. Now, the way that question was asked was there was what's called a gateway question. And so it said, have you been personally mistreated? Yes, no. If yes, then you would answer a bunch of questions about what that mistreated consisted of. Did you report it or not? That kind of thing. Starting in 2012, that changed. They got rid of the gateway question, and they asked everybody specific questions about certain behaviors. So were you asked to do personal services for somebody else? Were you marginalized? Were you given different grades based on your sexual orientation or your race? Were you publicly humiliated? So they didn't ask a gateway question. They just asked those questions. And if you take all those questions, roughly about a third of students throughout the country now report being subject to some form of mistreatment.
Do they ask questions that you, if there has nothing, let you observe that?
They do. So there's a set of questions that says about you, and then did you report it, and what was the outcome of that? And then it says, have you witnessed any of these behaviors happening to a colleague? So they do ask that as well. So the definition is mistreatment is either intentional or unintentional when behavior shows disrespect for the dignity of others and unreasonably interferes with the learning process. And so examples of mistreatment, and these are things that they asked individually on the survey, include sexual harassment, discrimination based on race, religion, ethnicity, gender, or sexual orientation, humiliation, psychological or physical punishment, and the use of grading or other forms of assessment in a punitive manner. One of the other panelists was Dr. Fried from UCLA, or the Geffen School of Medicine, who wrote probably the most influential study on mistreatment since those early reports. It was published in Academic Medicine in 2012. And actually got a lot of traction. It was Pauline Chen profiled it in the Science Times. And it was an interesting study because it was a negative trial, and which was fairly gutsy for them to publish. So what Dr. Fried and her group did is look back over several years between 1997 and 2009 at their mistreatment data on the GQ, and also some internal surveys on this issue, and looked at everything that they did, ranging from student education to trying to do faculty development to different reporting methods. And what they found, looking at their GQ data, the mistreatment did not change, and they weren't very exceptional in terms of a school. It wasn't that their mistreatment data was very different from a bunch of other schools, but it was something they were really focused on. And then when they collected qualitative data from their students and categorized things as severe or not severe, that data didn't change over that time. So again, I thought that was a very influential study because it really got this back on the map in terms of an issue and how difficult it is to change culture in medical institutions. In response to this, UCLA has done a couple of things. The most significant, I think, is they've added a new question onto every single evaluation form for faculty, which asks students to rate that educators on respect. So, did you feel respected by this educator? And then they give a scale, and if somebody scores below a certain level, that triggers an investigation. Surgery, which historically has been a clerkship where many mistreatment behaviors have happened at a higher rate, they surveil students as they're on the clerkship as opposed to waiting until later. On the other side of things, they're trying to reward good behavior, so they've instituted very highly visible teaching awards for humanistic behaviors in residents, and they've have a new publicity campaign, kind of like the anti-bullying campaign that a lot of schools have, that's been designed by the students. But the outcomes of those have not been shown yet. One of the other panelists looked at generational and cultural factors. Now, is this just different people seeing the same thing but with different interpretations? And they said, do millennial students have a different worldview than, say, baby boomers, and is that contributing to the, this is being more of a focus? They didn't have a lot of data to present on this. There was a study about 10 years ago which looked at different constituents looking at trigger tapes. So you watch a trigger tape of a behavior that's supposed to be mistreatment, and how do different groups view that, and do they qualify it as mistreatment or not? So they looked at students, they looked at nurses, they looked at attendings, and in fact, the attendings were probably more on the side of grading things as falling into the mistreatment threshold than even students. So there probably isn't a big generational factor. And then they asked about cultural factors. And there was limited data here, but they looked at reports from Canada, Finland, Israel, Pakistan, and Thailand, and all were fairly consistent in terms of the level of mistreatment and the fact that most of it clustered around themes of belittlement and verbal abuse in clinical settings. So there's definitely challenges in addressing the problem. There's varying definitions and perceptions of mistreatment. Even teachers who are in one domain are excellent educators. They may, by other students, be rated as mistreaters. Getting timely reports that you can act on and specific data that you can act on is very challenging. And setting up systems that identify and deal consistently with perpetrators has been an issue. The other issue that wasn't brought up so much at this plenary, but was brought up at another session, is that so much of the focus has been on students. How do you report it? Who do you report it to? How do you develop some resiliency and some thick skin around these things? And one of the people at this panel said that the focus should really be what about the culture leads to these kinds of behaviors in our educators? That's not really been addressed yet. So they suggested that PR is really important, that not only students should know about this, but clerkship directors, program directors, and leadership at all levels should know about mistreatment, and that it's an issue and affects learning environment. Establish codes of conduct that people understand up front so that they can be held to them if they do not live up to those codes. Identify several reporting pathways, and that's something that we've really taken to heart here at Sinai. We tell students several different ways that they can report mistreatment, either to their clerkship director, to one of us in med ed. There's a student panel to which they can run problems by. We have ombuds people who are specifically for students. So that's one way I think we've really made some inroads. It's important to follow up on all reported and unofficial occurrences, because if there's smoke, there may be fire. And then definitely monitoring frequency to see the outcomes for interventions. And so that is my 10 minutes on mistreatment. Do you want to have questions now, Reena? Or?
Yeah, maybe.
Okay.
Yeah, questions for Pete?
Yeah, Scott.
Any of the institutions talk about concrete ways that they've handled individual perpetrators?
Yeah,
there's no consequences. You don't lose $2, or you're not put in, in stocks outside the cafeteria or something. Nobody knows about it. There doesn't seem to be any consequence to being a jerk.
Yeah, they did talk about that it's definitely important to be as transparent as you can be, and also make sure that you get both sides of the story, but that there are real consequences, that these people don't teach anymore, or it's tied to something else, because you're totally right. And that's one of the reasons we see on the GQ data that students don't report mistreatment, is they feel like nothing's going to be done with the data. And again, it's we don't want to put people in stockades outside of the cafeteria, but we do try to tell students that action has been taken, and we have removed people from teaching services, or we put them on some sort of probation with an intervention. Those things have happened. But you're totally right. Yeah, Ken?
But some of it's very objective, like picking up your attending's dry cleaning.
Yeah.
That's either happened or it didn't. But a lot of it's subjective. So telling someone they're wrong when they answer a question at morning rounds.
Or that pimping business, you know, what's pimping?
Well, is that public humiliation, or so there's a lot of subjectivity to this. How do they sort that out in these questions?
Yeah, I mean that was a big question where I think they were trying to get at it with a generational discussion, and it's the kind of thing that if it's a loud signal, then that's something you need to really pay attention to. If it's sort of very soft data with very few numbers, then that maybe the educator needs to get some feedback about how they're perceived in some settings, and that person can take that to heart. But we definitely see it in the folks that we have looked at carefully. You look at their teaching evals, and even the folks who have had fairly egregious, fairly objective things, they also have tons of stuff that's very good in their data. It's not like these people are always bad, and a lot of times it's context specific. Somebody might be really, when they have a lot of time, they're excellent teachers, but if they're in the OR or rush for time, something like that, it's not. So again, even if it's not something where we take somebody off the teaching service, it's important that they get the feedback that this is how they're perceived. Yeah.
You mentioned that one of the reasons that students don't report is that there might be no action taken against the faculty. Was there anything else that they reported in terms of why? Because we have so many avenues that they can do that. Like you mentioned, the clerkship director and the deans, the ombudsman, but yet it doesn't seem that
Yeah, so definitely feeling nothing's going to fear of repercussions, because grading is even if it's anonymous, fear of repercussions. And sometimes if you have to take it to the next level and really investigate it, you can't be anonymous. So I think students are afraid of that. Sometimes they feel like there's, it's kind of futile. Why do I do this? It's just part of the culture. There's nothing I can do about it. And sometimes they think, I just need, they internalize and say, I do just need to grow a thicker skin. So there's definitely many reasons.
Pete, is there any data on residents or fellows in either getting mistreated or doing the mistreating? In other words, I think that comment about sort of the culture is probably critically important. If you look at those diagrams that they made around bullying in middle school, right, there's often, it's much more complicated than just sort of one person doing something to one person.
Yeah. In terms of the GQ data, it's the most common perpetrators are residents and faculty in clinical settings. Residents and faculty, almost equally. In terms of why they do it, I don't think, to my knowledge, that's been fully investigated yet. That'd be a really interesting study, whether they feel stressed or what have you. And then this has been much more, nationally, this has been much more of a conversation that's happened at the UME level and not so much at the GME level or the fellowship level. And you can imagine how you were a fellow, and how you're much more vulnerable actually as a fellow than you say are as a student in some ways, even though you're higher on the totem pole in terms of your workload and stuff like that. So it's not been as investigated. Bridget, I don't know if you want to mention what kind of things we've done here.
Yeah, so it's been 2 years now. We wound up taking, modifying the GQ questions and submitting and asking the chief residents to do them related to mistreatment. And so this was a select group, so it's just the chief residents who attended chief retreat, and more than half had witnessed some form of mistreatment, either sexual, physical, emotional, or verbal harassment. And then it was about a third had said that they were the recipient of such type of harassment, either from, mostly it was attendings, although we did ask about nurses and other members of the healthcare team. The common things were, verbal and emotional harassment were pretty high, but there was still, more than we thought. It was like 12% reported some form of sexual harassment, and then a variety of other forms in terms of combinations. And most had not the majority had not reported to anybody. And I think on that, because we wanted to keep it short, we didn't ask why, but that was data from our own consortium 2.5 years ago.
My sense is that as this cohort of medical students has gotten very used to questions like this in the GQ sort of reach the GME world, it'll probably become more of a standard to even assess it, I think,
Right.
at the sort of higher level, meaning across programs and across the nation.
It is it's a small part, but it is a part of the ACGME Clear domain. So within the professionalism domain, there is a piece related to mechanisms to report and to deal with harassment. Although I think in sort of the initial round of all this, they're focused on other pieces of professionalism. Now, I think over time this will grow, and they'll probably gather more data about
And it's
this.
in the survey, right? The retribution, there's a retribution.
Yes.
survey, yeah.
Yeah.
But it doesn't say anything about bullying or harassment. Right?
Not in the survey, yeah.
No.
Yeah.
They could be more specific.
Yeah.
All right, thank you guys.
We're going to talk a little bit about competencies and entrustable professional activities as those relate really to the UME world that's emerging through the AAMC. So I do not have any conflicts of interest as well. Here I think the goal is for us to recognize some of the key differences between EPAs and milestones, and then to think about what are the features of a competency-based educational model. So just to contrast the two different models that we're speaking about, the common model that has really been pervasive in medical education, both at the UME level, largely across the country, is the structure process model, right? Where we control the structure of learning and teaching activities, and we control the process by which you learn. So this is the way you will advance in this program. Here's what we're offering you. Here's how you're going to learn. It's a fixed time model in the sense that we say you will complete 2 years in 2 years. You will complete medical school in 4 years. You'll complete residency in 3 years or 5 years. But the outcomes, of course, can therefore vary because we've created these artificial barriers of time as really the markers of progress in this model of structure and process. And the flip of that is this idea of a competency-based model where we define what we want the product to look like at the end of our training experiences. And by defining that outcome, we say that when you as a learner meet those outcomes, then you're done. And so therefore time becomes really variable in this model. And you can almost imagine, just from my briefest of brief descriptions here, you can imagine how schizophrenic that would be in an educational environment, because we might have me taking 6 years to complete a program, and Kaushal could finish in 3 years and he's out. And maybe in an environment like the GME world, where we're also thinking about work and staffing, that could really create a whole potential for problems when you have people who leave in between a cycle, and then we have the work still has to be covered. So the competency model, though, is emerging much more in the education literature as a way to think about learning at the professional level. So in the competency model, outcomes are defined in terms of competencies, essentially, that you're defining what are the knowledge, skills, and attitudes that are expected of your learners or trainees. And so once you've defined that, you have to think of those knowledge, skills, and attitudes as observable. They have to be something that someone can look at, can watch, can see, and can measure. And they're generally context independent. So I could say, take a complete history on a patient. It doesn't vary if the patient's in an ICU, if the patient's in a ambulatory practice. It's taking a comprehensive history. So it tends to be context independent. The competencies, which are these knowledge, skills, and attitudes, then if you think of their trajectory in terms of building from them, they are then lumped under umbrellas known as competency domains. And what that might be is that these are broad areas that aggregate skills or knowledge or attitudes that fall under a broad rubric. So maybe taking a history, a complete history would fall under a patient care rubric, right? For if we're thinking about an undergraduate medical education framework. Now, entrustable professional activities, many of the GME people in the room have become very, very familiar with this, but Olin Tenkate was the first sort of educator in the medical field who started talking about entrustable professional activities. And he started this discussion because his whole view was that instead of thinking about very sort of arbitrary and very specific skills or knowledge, we had to think much more about how you spend your day in the profession. And so what are the routine units of work that you might need to do as a professional? They have to be critical elements of work. What are the things that you spend your day doing that are critical to you as a professional in that particular field? And because they're units of work, they integrate various competencies. In order to do a unit of work, let's say, for example, to admit and manage a baby into the neonatal intensive care unit, it requires patient care skills. It requires knowledge skills. It might even require a lot of professionalism skills. So the idea that a bunch of those competencies would then fall under these units known as entrustable professional activities. They have to be independently observable, just like competencies are, and they have to be measurable. But these are very much context specific. So that thinking about how to admit and manage a patient in the intensive care unit might be very different than thinking about how you conduct and care for a patient in the ambulatory care environment. And so that becomes, EPAs are very much context specific. So the two things that we really sort of have to remember about entrustable professional activities that the AAMC spent quite a bit of time talking about at the sessions I was at, this idea of the word entrustable really explicitly adds the notions of trust in there, right? So that as a supervisor, you have to feel comfortable and skilled enough to say that I actually feel comfortable entrusting this activity to this person by the time they leave. Can I say that I feel confident that they're able to do that? This concept of trust is built into EPAs. You, as a supervisor, you have to be able to infer a variety of different competencies under that broad rubric of EPAs. And then you acknowledge that the trainee has demonstrated competence to do it. Now, of course, if you're thinking of the GME world, when you certify someone on an EPA, you're saying basically that after you've certified them, that they can practice this independently. In the undergraduate medical education world, the focus is much more on whether you can say they can do it, and then they will be moving into supervised practice, right? Residency is still very much supervised practice. So if you think of this graphically, you can see that this idea that you have a variety of competencies there, those are the knowledge, skills, and attitudes that you expect of your learners. They can fall into different domains. So you might have a whole bunch that relate to patient care, for example, to communication skills, to whatever the domain is. And then you have your entrustable professional activities that then really map. So each EPA can map to multiple competencies and multiple competency domains. And those are the units of work that are relevant to you as a professional. So this was all happening pretty fast in the GME world. And the UME world has been much slower to think about this and adopt this. And some of the reason for this is this idea of you're transitioning learners into supervised practice. You're not certifying them for independent practice. And so this idea of the pressure felt very different to the UME community. And the other piece of this is schools are very much trying to distinguish themselves from each other. They don't want a one-size-fits-all model that basically says, you know, we're just like all the other 146 others. So this has been sort of harder to drill down at the UME world. So the AAMC had a consensus conference a few years ago with a variety of stakeholders where they tried to define what people would agree on as the graduation EPAs. And they wanted those to be the activities that all entering residents should be expected to perform on day one of residency without direct supervision. And by direct supervision, they meant someone with you. So someone standing there with you, watching you do that. And they came up with 13 EPAs. These are still, I have to admit, are still in flux because they've received a ton of stakeholder feedback that many of these are very generic, not very clear, and really in some ways might not represent really the culture of what's going on in medical schools. And some you will have great valence with them and you'll feel that they're fine. Gather a history and perform a physical exam. Develop a prioritized differential diagnosis and select a working diagnosis following a patient encounter. Recommend and interpret common diagnostic and screening tests. Enter and discuss patient orders and prescriptions. This one has gotten a lot of feedback from the AAMC community. Provide documentation of a clinical encounter in written or electronic format. Provide an oral presentation summary of a patient encounter. Form clinical questions and retrieve high-quality evidence to advance patient care. Give or receive a patient handover to transition care responsibility to another healthcare provider or team. Participate as a contributing and integrated member of an interprofessional team. recognize a patient requiring urgent or emergent care, initiate evaluation and treatment, and seek help. This has also gotten a lot of feedback. And then obtain informed consent for tests or procedures that a day one intern is expected to perform or order without supervision. So things like sending a person down for a CAT scan with contrast, things like that. Finally, perform general procedures of a physician. This has gotten slammed by the, as you can imagine. There's just a ton of variation in what that means. I know. What does that mean is really the correct question that everyone's asking. And they gave examples of things like, doing a urinary catheter placement, placing a PPD, doing venipuncture, drawing blood, and putting an IV catheter. And then identify system failures and contribute to a culture of safety and improvement. Also got a lot of sort of press in terms of thinking about, what does that really translate into for a day one intern, when the experience of a day one intern can be very, very different on a team, and sort of how do they play a role in this. So those were the 13 EPAs. They're still under a lot of discussion. And the AAMC has been very cautious about expecting these for all medical schools. They have said this is completely voluntary. Schools can choose some if they want, can choose none if they want, can continue just a competency model, can decide really what they want. But this is not going to be, they are not going to prescribe it, nor are they going to mandate it as part of even current or future accreditation. So just to take this back a bit and bring it home, I think, the idea of, where are we in terms of as a UME school. We have 4 competency domains. Those are those broad domains that I talked about, under which our knowledge, skills, and attitudes fall under. Patient care, scientific and medical knowledge, leadership, scholarship and collaboration, and professionalism and advocacy, very linked to our school mission. And just to give you an example, we have a description of each domain that's on the website. For patient care, for that is for our graduates to reliably obtain and interpret clinical data, propose a prioritized management plan, and communicate effectively with patients, family, and colleagues. And then under that domain of competency, we have a variety of knowledge, skills, and attitudes. Under patient care, we actually have 24 competencies, and here's just one: conduct a comprehensive interview that is organized and efficient, the appropriate elements of the history. So we have 23 others like this under this one competency domain, and this is one of 4 competency domains for Icahn. So what if we think about mapping our AAMC EPAs? How would we do there, and what would we do? So here's an example of that EPA that you had already seen: gather a history and perform a physical exam. For us, if you think of that graphic that I showed you about how EPAs map to domains and then map to competencies themselves, for us, that EPA maps to 2 of our competency domains: patient care and professionalism and advocacy. And as if we sort of drill even further in terms of which specific competencies that maps to, we can map it to 12 of our actual school competencies. And so for us, Rob and I are involved a lot now in sort of thinking about how to map our competencies to the EPAs to ensure that while this is not a mandate from the AAMC or us and doesn't intend to be an LCME mandate, the idea for us is really thinking about the fact that as a school we can meet the standard from our national organization. But I think even more critical, and this is something that the GME world is facing a lot, is this idea that you can talk about competencies, you can talk about knowledge, skills, and attitudes, you can talk about milestones, EPAs, you can sort of keep talking about this. But the idea is, how are you measuring it, right? So if you think of that structure or process way, it was enough a while ago to just say, well, I taught it. I don't know if they got it, but I taught it. And the idea now with this is that you have to actually demonstrate that someone has achieved those. And so as we think about our assessments, of which we have a multitude in the medical school, for us the next step is not only sort of this broad mapping concept, but this idea of how do our assessments actually directly link to each of those competencies in terms of knowledge, skills, and attitudes. And once we have that idea, that map then will really sort of back into the AAMC EPAs. So that was the update from EPAs from the AAMC. And I'm happy to take questions. It's very interesting. My sense, and this is just coming from the past year and a bit, is that because there is, sort of the pace in the academic medical center and the sort of pace of the floors and the pace of medical care, that when residents arrive, there is a real expectation that they be ready to start running. And what we felt is that we hear from a lot of program directors this idea about, well, what are you doing? Can they do informed consent? And surgery, for example, has put out its own and is going to come up with its own, what they consider almost like a boot camp for internship that they want medical schools to do for those going into surgery. So there's a ton of pressure, I will tell you, actually, from program directors that we hear that are about certain skills, whether they agree with this or not. There are a lot of expectations that are coming where the feeling is that if you've just got a student who's really had all the time in the world to kind of spend, 2.5 hours doing the history and physical and admits one patient a day, that is not, you're not coming into my program running. So my sense is that there's, and the perception of program directors that the fourth year is largely underfilled as an educational learning experience. So why not fill it with things that are really going to help them come into my program, running about. And so I think our focus now is less like you can do every one of these things and much more sort of what are the skills that program directors, that respected program directors would want in their first day intern, that we can really effectively provide our students and feel comfortable that it still fits the mission and vision of the school.
So I remember when this report came out, it was huge. It was one, like, all
And then
background,
right.
and then there was one sort of like just the basic, and I think we got a lot of feedback. I imagine that took years for them to just generate that. Do they say what their next step is? Is there going to be, it's an iterative thing, or is there going to be volume version 2 coming in?
They didn't say anything like that. My sense is that because it's not a mandate, that they're leaving it for people to kind of, almost own a little bit and change as you will, as you see fit. They have a project going on with, I think it is 7 medical schools right now that opted into taking one and owning one of these and saying, how would you build out what the competencies would be, what the levels of milestones, what the assessments would be. And there were several schools who went for it. And then a bunch of other schools that I know that are just doing mapping because they've realized, like, even though they're saying it's not part of an expectation for accreditation or whatever, we never know. And so we want to make sure that we at least at minimum really critically review them and think about them in the context of our places. But I don't know. I know Carol Ashton-Brenno was one of the big leaders of this and now is no longer at the AAMC. All right. Professor Parkas?
I have no conflicts. So I am going to talk about two presentations that I went to. One is sort of more in the curriculum sphere, and one is in the admissions sphere. This is from the University of Wisconsin, and it's more in the curriculum arena. And I think it resonated with me, and I thought it was important to discuss today because I spend a lot of time when I'm talking to applicants about our educational philosophy, and that our philosophy is really around adult learning and giving the students the tools that they can then work with, and that we believe that they are learning for their patients and that they're going to use everything to do the best that they can. And then I talk about the fact that we do not make lecture required, but that we make small group required. So I have this sort of spiel, for lack of a better word, that I talk to the applicants about, and I believe in it very deeply, and I think a lot of the people who do all the teaching also believe in it. But I think what ends up happening is that this sort of not required coursework ends up having an impact on the day-to-day experience of being a student here and a faculty member here. And this school, they were sort of struggling with if they should make small group required or not. And they put this into place, and I thought it was sort of interesting and worth discussing for a moment. So it's University of Wisconsin, 2010. It's a small course, so I don't know that it's applicable to our large courses, but it's a small pathophys course, endocrinology. And they replaced a system of small group attendance points with small group formative assessment opportunities. So what did they do? They took small group sessions and they contained a pre and a post-session quiz, which was comprised of competency type questions at the end of small group. In addition to that, they had weekly online quizzes, and all students took those. Those were online for all students in the course, 10% of the grade for all students. The small group quizzes were up to 25% of the grade, but they varied from student to student depending on if you went to small group. So you sort of could opt into getting that 25% of your grade, or you could say, I'm not going to small group and I'm not going to get that 25%, which takes out sort of us saying small group is required, but also takes out what I believe is we say small group's required because you're part of a team. The group is collaborative. The group is learning together. They're pushing each other, and it becomes part of our sort of, I believe, our educational philosophy here. But I think at University of Wisconsin, they were finding that it was a little bit more paternalistic, that they were saying you have to go, and students were fighting back against that a little bit. So at this school, in this small course, the final exam for some students was 90% of their grade, and for students who opted to not go to any of the small groups. But for other students who went to all the small groups and took all the post-quiz, small group quizzes, it was only 65% of the grade. So what they found, they gave 3 examples. So a student who attends all small groups answers all questions correctly. Small group is 25% of the grade. Online quiz is 10. Final exam 65. Student 2 attends some small groups, answers half of the questions correctly. Small groups 12.5% of the grade. Online quiz is 10% of the grade. Final exam 77.5% of the grade. And then the student that says, I'm not going to any small group. 0% of the grade. Online quiz is 10% of the grade, and the final exam was 90% of the grade. So it made it a more high-stakes exam. But the students knew that going in. So what did they end up finding? The legitimacy of the absence is determined by the student. There's no artificial makeup work, right? So they don't have to say, we believe that you can miss a small group if your sister's getting married, but if your cousin is getting married, we don't give that that's not an okay, right? So it takes the faculty out of sort of saying what's a legitimate absence. And it puts the onus on the student to say, I'm going to miss small group for this reason. Students are responsible to make up any absence simply by learning the missed material and demonstrating their knowledge on the final exam. Again, they're being the adult, they're responsible. It provides truly low-stakes formative assessment in small group. It offloads the final exam in perception, if not statistically, see the next slide, at lowering student anxiety, and it effectively incentivizes attendance without mandating it. Statistically, the final exam carries the majority of variation in student performance in the course. If students opt not to attend, the final exam is very high stakes. Poor exam performance carries a high risk of course failure. And they found that only 1 student in 2004 and 1 in 2012 failed this course as a direct consequence of not attending any small groups. They also showed a bunch of evaluations in which the students felt much more in control and a little bit less sort of mandated to do stuff. So I just thought it was interesting. It's not our model. The faculty in the room all had fairly direct questions about sort of percentage of students faculty members who are really course directors. I have not been a course director now in 7 years, I think, or 6. So probably those questions are a little less apropos for me, but I thought it was an interesting discussion. I can take questions on that, or I can go on to my second one, which is an admissions discussion. Pete.
I went to the session too, but I really liked this, but I can't remember, did they answer the questions in the small groups for, the kind of the 25% as a group, or did they do it?
Individually. They did it by the thing we own where you push
The audience.
that, yes. Yes, I don't know your name.
Jen.
Hi.
Do you know if attendance in the small groups differ by much compared to before they implemented this?
It didn't differ by very much. They showed data on that, and I apologize for not showing that. I think that what it did was just completely take student affairs or curriculum, whoever, out of it. I know we have an absent student sort of email account. And no, it didn't actually change that. I think when you own things, it changes less than you think, but it gives you the sense of empowerment. Yeah.
They went up surveying the faculty about their perception or sort of their motivation to teach in this kind of setting where there was variability in the composition of the small group?
They did not. Now, I would give it was probably like our endocrine. I don't know how long our endocrine, how many hours that. It was a small class. And I think the course director really owned all the lectures and was really probably she would have ended up having to survey small group leaders who are like her fellows and her faculty. And I don't know, it almost would have been maybe perhaps a little bit biased because she was owning it so much. Yep.
They haven't expanded beyond endocrine.
They haven't expanded beyond endocrine.
What are they waiting for?
I think probably she's not the head of the curriculum. She was a very lovely.
There was definitely talk of it.
There was talk of it. No, it seemed like it was. They were all in. She was excited. Right? Pete was there. Yeah. Yeah, Kathy.
Any difference in the final grade between the students who went to small group and those that did not?
she showed the data that really it didn't seem like that many people failed this course, and but I don't know the answer. I think most people went to small group. I think most people wanted that 25%, as I would, yeah.
Are they a pass-fail 1-2 or?
They are not.
Uh-huh. So there's a difference between getting 90 on something
Right.
and 85 on something.
Yes. So I don't know that the research part of it was so important, because I think it's kind of like low stakes outcome surveys of these of people who are on your committee, and you want them to say that they like what you did. However, I did think that the two things that I mentioned were kind of interesting. Number one, saying what makes you struggle at our specific institution, and can we dial back to admissions? And number two, just the use of these standardized applicants. Questions?
The standardized applicants, was it a real person or is it just their own interview question?
Like actors.
Is the right person?
I think
The standardized no, it was an actor.
who just looks really
Yeah, sorry. A script based. Like they went and searched their file for people, and then they sort of wrote up sort of a compilation probably and then they gave them a character, and they trained them in the Morshan Center, but it's not called that. Yeah. So what they do is that they have a larger, we have 30 minutes, which I inherited from you. So they have 45. And they have sort of a certain percentage of that is just sort of regular non-structured interview. And then they have some amount of time, 20, that is more structured. So they're doing, and there is good data, if you look at admissions data, that the validity of an interview goes up with more structured questions. But of course the enjoyment of the 45 minutes goes down. So they do they try to do both. Yeah, right. I don't know that you're selling yourself short, because I don't think it's just our process. I think that that's the literature. I don't think that it's right. No, I know you don't. But I think that's just the way it is. I'm like getting the cane. But I think that having one or two structured questions that get at, I keep pointing to Pete about promotions, but get at sort of issues that we put on our supplemental application, we changed it, and we now put a question about, tell us a time when you struggled in a collaborative group project, essentially, although not that specific. And it's been an amazing question, because there's people who have written, after thinking about it, they typed out, I was assigned to a group and I didn't like anyone on it, so I switched to another group. Well, okay, that's not good. Go to a different school. Yeah, so, so I think these questions that get at collaboration or sort of asking for help or that lens or, we could come up, I think they are, and we could put them between a structured interview, one or two questions, and a supplemental. We could maybe get at things that are important to our mission.
So we have 5 minutes, and I think
Take your time.
Get near the end. So I spent some time at this panel, primarily because I wanted to sort of look at, I knew what I thought some of the issues would be, and to look at the continuum of where we are trying to educate people in the undergraduate world, and then into the graduate world, and on to actually faculty development. So I have no conflicts. And these are the objectives, is to state the future directions for GME, and I think a lot of people in this room, a lot of this will resonate. And then the implications for medical education across the continuum, because there's real issues with where we're going in medicine in the 21st century versus where we're teaching and where people are now. And if you think, right, so the idea is now this, in 2020, even 2020, not alone 2025, when everyone in this room will still be educating people, will still be practicing medicine, what will it be like? Right now, people, 2025, you still going to be around? Right, so.
Is this recorded, sir?
Yes, exactly. So everyone here, he's resigning by 2025. And so think about the difference in the world. Right now, people, they go on computers and they go on up to date. They use iPhones to get stuff. but we have no idea in 10 years the incredible place where we're going to be. And we as the educators have to think about that. So I went to this panel, and I figured it would be pretty good. It was this Rebecca Brienza, who is one of the directors of the VA Centers of Excellence in Primary Care. This one's at Yale. There's about 5 or 6 of these in the country funded by the VA. And they are linking, they have linking primary care education, innovative primary care education, to practice redesign. Eric Holmby, who a lot of people in the room know at the ACGME, they had a resident, which I was very impressed, Andy Levy, who was a third year at U Chicago, and then Kenneth Lundmerer. And if anyone's familiar with him, he's actually a medical historian and has a degree, in addition to being an MD, I think it's an MA, not a PhD, from Hopkins, about medical history of medicine. And he has written a very good book from like the Fletcher period up to the 90s, discussing the history of medicine. So that's what this panel. So it was fairly different, which was really nice. And so what I did, and which why we'll be able to get through this in a few minutes, is I went through and I kept notes of everything that they were saying. And then now, back here, went through and found what are the themes, what are the big themes that these people are saying that we have to look at. And this is what came out. And then they didn't, in general, say these like this, right? So I put them together, except for AmCare. So assessment, practice redesign, teams, interprofessional education, and ambulatory care. And some of this links back to what Reena was saying when she talked about her competency-based education, which is something that's been in the vernacular for those of us in GME world. So this is what they said. The comment was need to observe, and they all just kept reiterating it. And they obviously commented on the lack of observation that we have in many of our worlds. And they said there really shouldn't really be any assessments except observation. Right? And so they gave examples here, which are familiar to a lot of you, direct observation, being always direct observation, using audit and performance data so that you're actually observing exactly what the person is doing, multi-source feedback, the idea of getting the team to look at the person, simulation, and then workplace assessment. And so just to put it out there for those of you who are thinking about what we need to do looking down the road, and this very much pertains to the undergraduate world and now has moved into the CME and the faculty development world and is a total black hole. Okay? So I think during these few minutes, I'm talking about linking the continuum. What are undergraduates doing now? Who are they? What are we doing in isolation in the GME world? And the lack of doing anything in the CME faculty development world. So that was that. Practice redesign was another big thing. And the key here is that it has to be linked to educational reform. Because what has happened in general, right, around the country in clinical settings is some medical director is deciding how they want their practice to run, and we're actually teaching them in the undergraduate world, you have to work in a team, right? But they're being done in 2 different silos. And this link to redesign, practice redesign, is really what has to happen. And I'll give you an example. So here at Sinai, when we think about the clinical practice, where I meet with the hospitalist actually to design educational programs, and I meet with the medical directors in the outpatient setting to design educational changes that we're thinking about. And the big focus is all around cost-conscious care now. And they gave this framework, which they called COST, which I thought was a nice way to think about it. Culture, oversight, system support, and training. So it really is, it's a whole bucket that must go together as you think about cost-conscious care. And there's 2 examples, if people are not familiar, which is these VA centers, which that's their initials down the bottom. And then the ACP online has a high-value care, which is essentially put together for you to get out there. So just a couple examples of how we can do that. Teams. The issue around teams, everyone works in teams. Here, in the undergraduate, you do some assessment of teams, but no one knows how to assess teams once you get, past sort of the initial, even in the undergraduate world. So the idea of people are going to be working in teams. How do you use teams to assess teams, but that reflect on the individual simultaneously? Is there really a disconnect there or not? No one knows the answer to that yet. And then how do we think about rewarding teams? And this flows into the obvious interprofessional education. Here, I think there's an incredible disconnect with what's going on. There's a focus in the undergraduate world about teaching teams. Some of our medical specialties have great use of teams, like in the care of the older patient, but how do we begin on doing this now, right? How do we do this, and when do we start it? I think that question has become unanswered. The earlier the better. Even some people talking about, getting it down to college, so that in admissions should really be looking at this too, in how people see IPE. But the real question for most of us is that there are hundreds of thousands of people who are out practicing who have not been trained in interprofessional education in a meaningful way, right? So tons of people who are in the graduate medical situation now, right, or in residencies and fellowships, have very little training in this, and those in practice have hardly any. There's hardly any in practice. So this is the big issue that I think we have to struggle with here. At the Sinai camp, in the Sinai system, what do we struggle with? We don't have other interprofessional students even, that we can sort of partner with, and that are on the floors that our GME people can train with. And then AmCare. It was very interesting that they went from those sort of topics, and there was a lot of focus on AmCare, and a lot of us in this room know that. And this sort of links back to the need for new models in AmCare is for practice redesign and educational redesign, right? So they both have to go hand in hand. Many of you may not know, but internal medicine residents, for instance, have to spend 1/3 of their time in outpatient settings. There is a paucity of education, a paucity of thought around that for many, many, many years. It's beginning to change now, but 1/3 of the practice is actually in ambulatory care. And so with the idea that we will move that to more time going forward in some innovative thinking. And so this one really does involve everything that we talked about so far rolls up into the AmCare, because the thought is we're actually exploding this and rebuilding it. So let's start from scratch and use all the things that are going to matter going forward, because in 2025, most stuff is going to be done in outpatient care, and very, very highly critical stuff will become in inpatient care. And so we need to learn how to do our own practice redesign, self-educate ourselves, and then begin to train other people to do that. So that was the big, thank you very much. That were the big topics around GME, and I think its applicability to how we sort of think about the transition from UME, what UME should be teaching, and then what we're doing in terms of faculty development. So happy to take a couple questions. There's a couple after one if anyone has time.
Here at Sinai, what are some of the thinking as far as how to incorporate these 5 areas in our residency education? I wonder if there are developments in any particular of our residencies.
Mm-hmm. I can speak from medicine perspective. From the more school perspective, we'd have to ask, Scott and Mike and the other deans. But these are the areas that, as we're beginning to think about the educational strategy for the 5-year plan for the Department of Medicine, all this stuff is going to be in it, and figure out how to do it, which includes things like going, right now we're applying for a HRSA grant to try and do more primary care education that involves AmCare and interprofessional education. The resources in this stuff are not present. And so I think by having these dialogues, with various disciplines, GYN, OBGYN in the room, is where we're going to begin to try and move it forward. But this is on the Department of Medicine's strategic plan for resident training.
From the institutional perspective, there are a couple of issues. One is we don't have, there are pockets of simulation activity, but we don't have a state-of-the-art or anything close to state-of-the-art simulation center, and there's right now there's no space or money. Simulation is pretty very important. And there's a big practical issue around direct observation. It takes people away from what they would be doing, their research or generating income, to do that. And departments are, they're under tremendous pressure to generate money, and it's very hard to do that in today's world in a practical manner.
Yeah, all these 5 things are not easy to do. Yeah, Rich.
There's a book called The Second Machine Age that was recommended in the regions. It talks about the second machine age being digital technology, and what's going to happen to digitization over the next 5 to 10 years. How does that affect education?
That's a great, thanks for that. That's great. Yeah, I think we all need to be thinking. I think most of us in this room have to change our paradigm because we were educated in this older system too. I think in this room there's a lot of innovative people and people are trying, but the technology is changing so rapidly. That's great. Thanks.
Thank you all. Please complete your evaluations, come back for grant rounds, and thank you again.